Good evening, everybody, and welcome to this Care Paths to Parenthood evening. My name is Professor Charles Kingsland, and I'm the Chief Medical Officer for Care Fertility, which is Britain's largest independent fertility group. I'm broadcasting tonight from our head office, the Ivory Towers in Nottingham, which is just actually a couple of miles from where I was born and spent the first 18 years of my life before I emigrated to Liverpool. So tonight, what we're going to do is we're going to go through a few bits and pieces about care fertility, what's involved with an IVF cycle, what you might need, what you might experience, the general outcomes. We will also have some more information about methods of payment if you don't qualify for NHS treatment, additional services. And also, I will be answering a few questions that you might send in during the meeting. We've had quite a few questions. So what I will also do is we have some of my colleagues, the girls, manning the phones now and the email. So if we can't get to all of your questions this evening, what we can do is get back to you in the fullness of time. So the first thing we're going to do is to start off with an introductory video, which we'll play now, and then we'll come back and go through the IVF process.
Family. It's who we are and who we're always going to be. It's the important little moments. The big emotions. The beating heart at the centre of our world. It's the journey that we take there, together, one step at a time. Family is the one thing we'll always care about the most, because we believe that family is for everyone. And through our care, we'll do everything we can to make your dream real. We don't just care, we are care.
My name is Professor Charles Kingsland, and I'm the Group Clinical Director for Care Fertility. At Care, our number one belief is family for everyone, and this means we do everything possible to help everyone start or grow their family. We know that nothing is as important as family, and that's why we care so much about wanting to give every patient that comes to us their best chance of having a baby. Of course, families come in all shapes and sizes. We get heterosexual couples, couples of the same sex, we get single patients wanting to start a family, we get NHS patients. When you have a fertility problem, there should be facilities available for you to get the best advice and the best treatment readily available to give you the best chance of having a baby at a time in your life that is best for you. We will use all our knowledge and experience combined with highly individualized treatment, personal treatment, to help you have the family you are longing for.
Unbeknown to Gemma and I, we both carry a gene, a deafness gene. We actually have a daughter who was 3, but who was born prematurely deaf. And we were given the option and chose to go down a fertility treatment to kind of avoid our second child having that same gene.
We were very lucky in the fact that the clinic was only down the road from us. So we felt there was one around the corner. It had good reviews. We just felt it was good for us, didn't we?
The whole package made us just feel really comfortable that actually going with Care was the right decision.
So the team that we worked with at Care were unbelievable. They were caring, they were sensitive, they were compassionate, empathetic, and even when I was ringing out with I was feeling pains down one side, that the reassurance that they gave me, they honestly do hold your hand every single step of the way, and I feel like they lived the journey with us.
So I've had several treatments with Care, and I now have a baby, and that's taken a number of treatments, fertility treatments, different alternatives, different medicines to try and get it to work for me. I have always said I would recommend Care Fertility. I would recommend them for the comfort factor that I received, the friendliness, and just I think the word is my faith in Care Fertility.
Okay, so let's go through a few slides about the care fertility network. We started our first fertility clinic in Nottingham in 1997, and we've gradually grown more rapidly over the last few years to have 15 clinics throughout Great Britain and a number of satellites in places like Grantham and Boston. So we now cover a large network of the country, so that hopefully there is a fertility clinic, a care fertility clinic near you. We have a general inquiries team manager for all patients who want to dial in, and there she is. Sorry, I was just getting a bit carried away with my slides there. Shah I spoke with Shah this afternoon. She's our general inquiry team manager, and she and her team are there and available for you to phone in, and they will point you in the right direction, whether you need advice or whether you need a clinic appointment. It's important that we get the right diagnosis for you at the outset. So you will be asked, if you're having difficulty achieving a pregnancy at a time in the life when you want to have some basic fertility tests. Now, either the GP can do them or your local hospital, or indeed if you want to phone us directly, then we can arrange those tests for you at our local clinic. All our information when you come to care is put on a portal for you, which you can access at any time. So you can either be on your desktop, laptop, or on a mobile or tablet, so that your information and documentation is available for you, and we can communicate at that in that patient portal. So your journey with care would normally start following your initial contact with our general inquiries team with the consultation, and you will see either an advanced nurse practitioner or more likely a consultant gynecologist at your local clinic. And here we have George, one of my consultant colleagues, who is the medical director in Sheffield. They will go through your history, examination if we think it's necessary, and then you will have a series of relevant investigations for us to make a diagnosis and offer you the treatment that you need. Now, not all of treatments rely on IVF, but I'm going to talk to you about the IVF, where many of you who are dialing in tonight will probably be at that stage now, and also, you know, the majority of patients will require some form of in vitro fertilization. So the IVF process is fairly standard, and this is a diagram of a female pelvis, and you can see at the bottom of the vagina, the uterus, the fallopian tubes, and the ovary. Now, a normal female uterus, or the womb, is about the size of a clenched baby's fist. So that gives you some idea of the general size. The fallopian tubes are like the length of two little fingers, and then we have those sea anemones at those fronds at the end of the fallopian tube, which envelop the two ovaries, which contain the eggs. And each month an egg will grow and then pop into the fallopian tube and travel down. And if you have sexual intercourse at the right time, then sperm will meet the egg, usually in the outer third of the fallopian tube, and with a bit of luck, fertilize the egg. When that doesn't happen for whatever reason, we use IVF. And this is the process that we use. Obviously, there'll be variations for individuals because we have an individualized patient process, but these are the general principles. First thing is ovarian stimulation. We don't want to collect one egg. We want to collect as many eggs from you as we safely can. So that involves what we call ovarian stimulation. We give you a series of injections of a hormone called FSH, follicle stimulating hormone, which collects eggs and causes them to grow. So we don't want just one to grow, which happens in a natural cycle. We want 7, 8, 9, 10 eggs to grow and develop. And as they grow, with the daily injections, we monitor that particular growth. The eggs grow in follicles, which are little fluid-filled sacs, which you can see on ultrasound scan. So maybe once or twice during the course of a week, 9, 10 days, we will ask you to come to the clinic for a scan to make sure that your eggs are growing in the follicles nicely. We have nurses to teach you how to give the injections, because it's a pretty daunting prospect giving yourself injections if you haven't been used to that yourself. But it's a little bit like being a diabetic for a week. The needles are very fine, but you have to use them properly. So we have a website where we can show you how to use them. And if you wish, you can come to your local clinic, and here's one of our senior nurses demonstrating how you administer those particular drugs. This is the vaginal ultrasound machine, which monitors the growth and the development of your eggs over the course of your stimulation. In the top left-hand corner, we have Dr. Rachkawa, who is a consultant and medical director at our Birmingham clinic, and she's demonstrating vaginal ultrasound machine. And what it involves is you having a probe placed in the vagina close to your ovaries, so that we can have a really good view of your ovaries and measure the growth of the follicles. It's not the most pleasant thing you've had in the world, but it's relatively pain-free and takes about 5 to 10 minutes each time you come. When your eggs are ready for collection, when they're mature, we know that they're mature when the follicles have grown to a particular size, usually between 18 and 20 millimeters in size. We will collect them. And that involves you having a late night injection 35, 36 hours before your egg collection, which creates the final maturation of the eggs. It finishes off the ripening process, if you like. So we know that when your follicles have reached a particular size, that injection will finish off the ripening process, and then we are ready to do the egg collection. Now, the egg collection is done under sedation. Normally, it'll be done with intravenous sedation, so you're not anesthetized, you're just knocked out for 10 or 15 minutes. So the vast majority of women who have this procedure will not feel any significant discomfort. Obviously, that doesn't occur for everybody. Some people will find it mildly or moderately uncomfortable, in which case we can give you additional analgesia. And it normally takes about 10 to 15 minutes. And again, what we do is by vaginal ultrasound, we put a little needle through the top of the vagina directly into the ovary and then suck out the fluid in the follicles. The fluid is then put into a test tube and passed to our embryologists who are on standby in the laboratory to identify the eggs. During this time, we are preparing a sperm sample. It's either produced fresh by the male partner, or if you're a same-sex couple or an individual woman having treatment with donor sperm, then that sperm may have been frozen. We thaw it out and then make it available for use in the fertilization program. So This is the egg collection procedure. We fertilize the eggs one of two ways. If the sperm count is good, then 100,000 sperm are incubated with an egg, and hopefully within 24 hours, one sperm has swum into the egg and fertilized it. And you've got the beginnings of our embryo development. If, however, on occasions, and increasingly this is the case, the sperm count of the male partner is very poor, then what we do, if we're not confident that one sperm will swim in, we actually take the egg and inject a single sperm into the egg to sort of force the issue and create the fertilization in the laboratory. This procedure is called ICSI. And ICSI stands for intracytoplasmic sperm injection, or ICSI as we call it. What we then do is we have a process whereby, following fertilization, we monitor the growth and development of the embryos over 3, 4, or 5 days. Now, this can be done by a standard method whereby we take the embryo out of the incubator and examine it under the microscope and then put it back in the incubator. Or we use a closed incubation system, which we're very proud of, which we call care maps. And this is where the embryo is put into our incubator and we close the lid. And every 10 minutes, a photograph is taken of the embryo to watch its growth and development. And these pictures, the embryos are then measured, and all the measurements, the growth and development, are then put into an algorithm, a computer program, which then predicts, based on the growth and development, which embryos are likely to turn into a baby. So in some cases, we will biopsy an embryo. So what Care Maps does, it gives you an evaluation of what we call the morphokinetics. Morphology means the shape and what the embryo looks like, and kinetics means how quickly it's growing and developing. And that gives us a sort of a roadmap as to which embryo is likely to turn into a baby. If we want further proof, in some cases what we can do is we can biopsy the embryo and take 3, 4, or 5 cells out of the embryo and look at the chromosome development of that embryo, and that will tell us whether the embryo is euploid, i.e. it's got exactly the right number of chromosomes, or aneuploid, whether it's got an abnormal number of chromosomes. What we have to remember, humans do not always produce normal chromosomes. That's why normal embryos with normal chromosomes, that's why we don't get pregnant every month. And the older we get, the more likely is that the chromosomes are likely to be abnormal. So when we reach the age of 40 and we create embryos, up to 75% of those embryos will be chromosomally abnormal. That's why we don't get pregnant every month. Or the rate of miscarriage increases because the embryo is just not viable. And here we have a picture of an embryo developing over the course of 1, 2, 3, 4, 5 days. And as you see, it's getting bigger and bigger. And here we get to 4 or 5 days, and then that embryo starts to differentiate. It develops into part of the embryo, which is becomes the baby, and then a part of the embryo which becomes the afterbirth. Okay, next slide. Next one. So we've collected the eggs, we've fertilized the eggs, we've created some embryos, and now it's time for the embryo transfer. Some of you will have an embryo put back what we call fresh. So after 5 days, one embryo, which we deem to be of significantly good quality, will be replaced into your embryo, but into your uterus. But increasingly, we tend to electively freeze embryos. Certainly any spare embryos that are likely to turn into babies, we would freeze for future use. So you've got a little frozen family in our cryopreservation tanks. But some of you, as I say, will have a fresh embryo. The chance of success are exactly the same, irrespective of whether the embryo is fresh or frozen. And sometimes you will be given a choice as to what will be best for you, and we will discuss your likely chance of success with fresh or frozen in collaboration with our embryologists and also our doctors. So the embryo transfer occurs, if it's a fresh one, 5 days after fertilization. And it's a simple technique. Again, it's done with ultrasound guidance, but this time the ultrasound is placed on your tummy with a full bladder. And the full bladder does two things. One, it enables us to see the ultrasound waves pass through fluid much better than solid, so it gives us a better view of the uterus. And also it enables us, for most women, it will make having a full bladder flattens the passage through from the cervix into the uterus. It makes it more easier for the doctor or nurse practitioner to put the embryo where we want it to go. So the embryo transfer is very straightforward, and we put a little catheter through the cervix into the uterine cavity, and then carefully inject the embryo into the top third of the embryo cavity, and then remove the catheter, and then you're free to go. It normally takes about 10 minutes. What patients need to remember is that when you stand up after an embryo transfer, the embryo actually floats upwards. It's like a little bubble in a bottle of pop, that if you turn the bottle round, then the bubble floats further up. And that's exactly the same with an embryo that you replace at embryo transfer. Patients often have this fear that when they stand up, the embryo will drop out. Actually, it doesn't. It floats further up. So we encourage patients to get up and mobilize fairly quickly after an embryo transfer. But if you want to lie there for 10 or 15 minutes, that's absolutely fine. Now, and then of course, we've got the 2-week wait, that dreaded wait from the time you have your embryo transfer to the time you get your pregnancy test. We can't make it quicker. We have to wait to see whether that embryo is taken to a large extent. We're at the mercy then of the quality of the embryo, the quality of your uterus, and nature itself. There's very little that you can do to improve your chances. You need to take a lot of a hormone called progesterone, which is a sticky hormone, which helps the embryo to stick in. But, you just do normal things. You don't need to go mad, but just keep the blood flowing and keep mobilizing and keep your legs moving, so you've got a good flow of blood to your pelvis, which will maximize your chance of success. Now, there are some cases where our patients do not have eggs or sperm of their own, in which case we will offer a program called egg or sperm donation. In same-sex couples, of course, we will use donor sperm, which we keep in our donor bank. But some cases with females who do not have any eggs, or indeed have reached an age where their own eggs are no longer viable, we can use eggs which we match from our egg donor bank for that particular patient, along with your characteristics. And that's a program that we call egg donation, which can be very successful in the right patient. So as Charlotte says here, everything you're feeling is valid. Your journey along this IVF pathway, we recognise, can be very, very stressful. Not only are you dealing with the fear and anxiety and hope of achieving a pregnancy, but you're also going through what is a very stressful, although not particularly complicated, procedure. So we are here to answer your questions and try and solve your anxieties. And it doesn't matter what the question is or how daft you think it is. We are here to do our best to make you feel better and answer those questions. And believe you me, if you think your question is daft, I will have heard 1,000 dafter ones. So it doesn't matter. We are here to help you. Now, 40% of all patients who do not qualify for NHS treatment will come to Care Fertility in the UK for their treatment. And up until recently, we used to use an external provider or rely on other providers or the patients themselves to fund that treatment. But following surveys with patients and feedback from patients, we decided that using a third party, an external funding program, was not in the best interest of the patients. It caused confusion and difficulties. So we brought the payment program in-house, and we call it Care Pay. And this is an exclusive IVF funding program to make funding of your treatment easier to manage. We have different programs for different people, and our Care Pals facilitators and indeed our clinic staff can help you if not only with the clinical and medical side of your treatment, but also the financial side, because we recognize that you know, financing this treatment can be expensive and it can be quite onerous. So we want to make the whole of your journey, not only the clinical side, but the financial side, as straightforward and as easily to manage as possible. But crucially, you need to know exactly how much this treatment is going to cost before you start. So you have a realistic outcome, a realistic idea of your clinical outcomes, what the treatment entails, and how much it's going to cost you. Just to remind you again, if you have any queries, you can call our new patient inquiry team led by Shah on the number 08800 564 2270. Okay, so I think now we've got some questions and they've been flooding in. So I'm going to answer some of these questions. I have mild Crohn's disease. Can this impact my fertility? Crohn's disease is a disorder of the gastrointestinal tract, and it's a chronic inflammatory disorder that can affect anything from your mouth to your rectum. It can be very mild, it can be very severe, and can be debilitating. Now, generally speaking, any chronic inflammatory process can affect your fertility, whether it's Crohn's disease, psoriasis, rheumatoid arthritis, diabetes, any of these chronic diseases that cause inflammation. Crohn's disease is no exception. I know plenty of women and men, for that matter, who have had Crohn's disease and have gone on to have successful pregnancies. However, there is no doubt that if you have a chronic illness, then that's not, it's not a positive. It's not going to increase your chances. Particularly in men, if they have Crohn's disease and they're treated with a particular drug called salazopyrin, which is a drug that alleviates the inflammation of Crohn's disease and therefore makes the symptoms better, but it has a very negative effect on your sperm count. So if you do have Crohn's disease, it's important to think about your fertility earlier rather than later, particularly if you're on any of these therapies that can affect your fertility over and above the disorder itself. So my advice to you would be get advice regarding your fertility if that's what you want to do, earlier rather than later, and try for a pregnancy, but don't try to for too long. If you've had an operation for your fertility, for your Crohn's disease, like some part of your bowel removed or a colostomy, then there is a good chance that that's affected your pelvis. And so you've got a mechanical problem in your pelvis, which can make your fertility problem more significant. So if that's the case, get advice early. For patients with suspected endometriosis, would you suggest a laparoscopy is performed before IVF or wait until afterwards? Well, it depends what's bothering you most. If you've got, your age is very important. Have you got time? What are the symptoms like? Do you have a lot of pain? And it might be that you want to get rid of the pain before you go ahead to try for a baby and, have fertility therapy if that's necessary. My advice to you would be, what are your priorities? What you also have to remember, if your endometriosis is mild or moderate, treatment of endometriosis does not improve your chance of having a baby. It will improve your chance of having less pain and less complications, but it does not improve your chance of getting pregnant. So a diagnosis of endometriosis per se would not bother me unduly to the point where you need laparoscopy. If your endometriosis is significant, then we should be able to see it on ultrasound. You don't need laparoscopy, okay? How do you manage patients when the male has teratospermia? Well, it depends what teratospermia. Terato means abnormal, zuo means moving, and spermia means sperm. So you've got abnormal, poorly moving sperm. Believe it or not, we produce a lot of sperm that are abnormal. A normal sperm count only needs to have 5% normal sperm. So in a normal ejaculate, 95% of the sperm are abnormal. What we do want, though, is a good number of sperm, over 20 million per mil. Yeah, a lot. And they need to be doing front crawl. They need to be swimming well. We want at least 40% to be swimming well because they've got to swim a long way. And I've said before on previous Instagrams, for a sperm to swim from the vagina to the egg is the equivalent of a man swimming from Liverpool to New York at 600 miles an hour. So you've got to be doing, some of them have got to be doing front crawl. So if they've got a low sperm count and there's a higher than normal abnormality rate, crack on with some treatment earlier rather than later. There's a lot of things that cause teratospermia, and oligospermia, low sperm counts, which your doctors can advise you about. But if you've got that problem, then the chances are we're not going to want your sperm to swim. We'd prefer them to fly them over to New York as opposed to letting them swim and micro inject them into an egg. And I have seen men produce babies where their sperm count has been 5. Not 5 million, not 5,000, but 5 normal sperm. So never give up hope, but seek advice early. Does having an underactive thyroid decrease the chances of IVF? Absolutely. Yes, it does. But if because the thyroid hormone, producing a hormone in your pituitary gland that acts on your thyroid, is produced right next to the hormone that stimulates your ovary. Thyroid hormone affects your basal metabolic rate. And if your basal metabolic rate is abnormal, then your fertility, the chances are your fertility is abnormal. However, the good news is that if you correct your low thyroid, then that should correct your fertility. So if you do have hypothyroidism and you are thinking about having a baby, make sure that your hypothyroidism is as tightly controlled as possible with thyroxine, and your GP can help you with that. Just say, I want to have a baby, I'm trying for a pregnancy, I need to have my thyroxine as tightly controlled as possible. Okay, how long after endometriosis surgery should I have a frozen embryo transfer? Depends the extent of the endometriosis surgery, whether it's extensive or mild, but the whole purpose of having endometriosis surgery is to reduce the endometriosis if it's affected your fertility, if it's extensive, so you don't want it to come back. So you need to crack on. And I would say, provided you've got over the surgery, whether it's been laparoscopic or through a big incision, then 6 weeks to 3 months once you're symptom free and are mobilizing and are ready to get going. We've just had a baby delivered in Liverpool from a girl who had the most extensive endometriosis. She was really debilitated, and she had endometriosis affecting her rectum. She had a colostomy because the endometriosis was so bad, and she's just given birth to a gorgeous little boy. And I've got the photograph here with me, but I won't show it because we can't divulge identities. But congratulations, you two. I'll be seeing you soon. Vitamin supplements to take support us trying to conceive. Well, this is where evidence-based medicine comes in. What vitamins and minerals are unequivocally of benefit to you to improve your chance of having a healthy baby? Folic acid, okay? A good diet, maybe vitamin D, but everything else is not necessary provided you've got a good diet. These are things we call add-ons. There's no scientific evidence that taking alpha, beta, gamma glutamate, placental transferase, or a gamma GT, or this whatever, is going to improve your chance of getting pregnant. You might feel as though you want to. You might feel as though you want to go to the health food shop and spend a lot of money on vitamins and minerals, but they're not going to improve your chance of getting pregnant. You might feel as though, why not? They're not going to harm you. And, I've heard patients say to me, oh, well, I went to one, I took minerals and vitamins and all this, and I got pregnant. Well, that's called coincidence. It's not cause and effect. Folic acid, maybe vitamin D. I like vitamin D. We're all vitamin D deficient, and that helps us. Anything I should ask at my consultation, ask everything. Write it all down. Right, what's my diet? How do I get a diagnosis? What's the best treatment for me? What are the chances of success? How much is it going to cost me? Do I qualify for NHS treatment? Write a whole, prepare, ask the questions, prepare what you need to do. Don't just go in there to see your doctor or nurse practitioner cold. Ask the questions that are important to you, but you want to come out with a realistic idea of what needs to be done, what are your chances of success, and what are the costs, not what are the likely costs, how much is it going to cost? Is IVF always recommended, or are there other things we can look into? There are always other things. IVF is only just part of what we do. And IVF is the, people always think that IVF is the be all and end all, but it's not. Most people now will benefit from IVF because IVF in the right patient at the right time is a very successful treatment. And it's, for those, even though it's not successful, it's the best option. But there are other options, and we don't just jump in and do IVF. We need to do the least invasive treatment that gives you the best chance of success. How common are unwanted and long-term side effects with IVF, such as cysts developing the breast, etc.? Well, IVF is a very safe process. Having babies is complicated. People often say to me, what's the biggest complication of IVF? The biggest complication of IVF is having a baby. That'll kill you, but we don't think about that. IVF, in the vast majority of people, will be as safe as houses. And fortunately, thanks to good gynecological and antenatal care in this country, it is. IVF, the complications of IVF pale into insignificance compared with the complications of pregnancy. That's why we have to take a holistic approach. That's why we have over 60 consultants working with care who have expertise in all aspects of fertility therapy, from the beginning to the delivery. So we can give you that advice that you need, not only to help you get pregnant, but also to deliver a healthy baby. Success for us is not a positive pregnancy test. Success for us is a healthy baby. Now, the majority of patients that undergo IVF will have minor or sometimes moderate symptoms, usually related to the hormones that they've got and the anxiety that you feel and the stress that we've alluded to earlier. Yes, you might feel bloated, you might have headaches, you might feel a bit, you might have a bit of mood swings, but these are all self regulating. I won't tell you about the complications of having families, but that's because that's what we want to get to those problems. But generally speaking, symptoms are mild. There is one symptom syndrome that we try and avoid, which is ovarian hyperstimulation syndrome, which can be quite nasty. But nowadays, due to our new techniques, we can virtually negate that risk for you. Okay, I think we've got a lot of questions. My husband had a slightly overactive thyroid. Will this affect outcome with ICSI? Possibly, but adequate treatment, make sure his thyroid gland is regulated as well as possible, then that should solve the problem. Can you talk a bit more about increased risks to babies born via IVF for autism, low birth weight and preterm, please? So IVF, just very briefly, IVF babies are every bit as healthy as normally conceived babies. There are a lot of scare stories about babies being born with autism and abnormalities. That's not the case. If you could say that there are increased abnormalities with babies born from IVF, but that's due to maternal age. The older the female is having a baby, the higher the risks of an abnormal baby. And so women that have IVF tend to be a little older than those who conceive naturally. But if you take that into account, IVF babies are every bit as healthy as normally conceived babies. Now, you might say that, okay, that there was a fear about babies being born by ICSI, whether they would have abnormalities. Well, they may turn out like the dad. And if you consider that to be an abnormality, well, that's the way it is. But it is really not worth thinking about. So babies born with autism, low birth, there are some cases where babies are born with low birth rate and preterm, but that is mainly due to maternal age, the fact that or the reason why the couple have a fertility problem, not the IVF. The IVF won't give you autism, and it won't give you low birth weight, and it won't give you preterm, but the reason why you're having fertility treatment might do. Gosh, I think there's a lot of questions coming through now, but shall we crack on with the next video? And if we've got time, I'll answer some more questions at the end.
I'm Shah, and I manage CARE's new patient inquiry team. We're here to make it easy for you to take your very first step in your fertility journey. We completely understand how nervous and excited you might be when you contact us. This is the start of a life-changing process and hopefully the beginning of an amazing future as a family. So it's really important that we give you all the information you need. That way, we can help you to feel much more comfortable and confident with your treatment. Whatever you need to talk about, I want to reassure you that no question is silly or trivial. We appreciate that there might be a lot to take in at first, but don't worry, we'll send you a clear information pack about the treatments you're interested in, and we're always here for any follow-up queries. My team also manage inquiries about Care Pay, our range of funding packages which are exclusive to Care Fertility patients. When you're ready, we can book you a virtual consultation with a specialist fertility doctor from your local care clinic. So if you want more information, have a question, or wish to book an appointment, call my team. We want you to know that we are here for you at every stage of your fertility journey. We say that our patients become part of our care family, and it's true. We care deeply about you and your future, and our teams are here to make sure you have all the support you need.
The reason why we chose CARE was just, one, the care that they give you, the aftercare that they have available to you, and the fact that they offer different forms of treatment, and they listen to you.
One thing that I've identified and what I've noticed when speaking to other people that I've met within the infertility community is there's a lot of clinics out there that don't necessarily listen to you as the patient. It was kind of a one size fits all, but with care that didn't seem to be the case at all. They took everything into consideration, they listened to your concerns, they listened to you as a person, and they put a package and a process in place that will help you, and fingers crossed will give you that positive result at the end of it. So without a shadow of a doubt, if I had to go through it again, I would definitely go back to care.
Oh, the support at care was brilliant. Yeah, I mean, the nurses were brilliant for us. You feel so
looked after,
and cared by the whole team. We felt that they did care, and it wasn't just for them getting something out of it. It was actually that
ongoing support.
Yeah, and they wanted it to work for us.
Care Fertility started over 20 years ago with one clinic and the goal of helping patients achieve their dream of family through truly personal care and the most scientifically advanced fertility treatments. We've grown from that one clinic. We now have clinics across the UK, and many people have become part of our care family with over 50,000 care babies in the world. But one thing has and always will remain the same. We care for each and every patient. We care about your dreams of having a baby, and we put our heart and soul into every aspect of what care can offer you. To provide you with the best care possible and to give you your best chance of success and treatment, we look to our own care family. From our consultants, embryologists and nurses to our admin teams and specialist fertility counsellors, we've also put a lot of thought into how we improve each and every step of your journey, which will no doubt begin with lots of questions. We know that thinking about starting IVF can be daunting for some, and that's why our care, patient services and support teams will always be there for you whenever you have a question, need advice, or simply want someone to talk to, so that you feel completely confident and in control of your fertility options. So yes, we have grown and developed over the years, but care and empathy are always at the heart of who we are. We are passionate about changing lives and creating futures, and I hope that this shines through in everything we do and everyone you meet at all of our clinics. We don't just care, we are care.
Okay, I'll just have time for one more question. I promised Anna that I'd answer this one. This lady is 39 years old. She has possible male factor infertility, and she might be saving for private treatment because she may not have access to NHS treatment. My advice to you would be, if there is a possible male factor problem as diagnosed by your GP, then your age is not working for you. So I would crack on as soon as possible. Get the right advice from your local care clinic. Get the tests you need. It sounds though you don't need very many. You need a test of egg reserve. You may need a scan, and your husband's already had his sperm test. And get your treatment, because treatment gets less successful as you get older. So the sooner the better. It's not just the male factor problem now, it's your age. So my advice would be to crack on. So we've run out of time now because our caretaker is about to kick us out of the building. So we better get off and get home and get our tea. But we just believe very passionately at Care that we need to communicate and talk to you. Everybody has a right to family life, irrespective of gender, age, sexuality, whether you're a same-sex couple, whether you're an individual. We are here to help you. Ask questions, ask lots of questions, get the right tests at the right time, get your right treatment, know how much it costs, and then one final thing, you just need a bit of good luck. So with that, I will wish you a good night, and if you have any other questions, we will try and get back to you. Our girls on the emails will answer your questions via me and the other doctors, and who knows, may see you soon. See you. Bye.
1 in 6 people need help to grow their family. You're not alone. And our Care family will do everything we can to help your dream of family come true. There are over 50,000 Care babies in the world today. And behind this success is our promise to make more heartfelt dreams of family become reality by ensuring our care goes into everything we do for all our patients every single day. You will receive truly individualised treatment, a patient-centric approach with empathy at its heart. We understand how nervous and excited you might be about getting started, but you can be assured of kindness, empathy, and all the information you need from our new patient inquiry team. We are all here to make it easy for you to take your very first step in your fertility journey. Call our team on 0800 564 2270 to learn more and book an appointment. We don't just care, we are care.